I really want to show you the bottom of my foot, so it does smart. There we go. Oh, that was ridiculous, wasn't it? I'd be the first to agree with you. How immature. Okay, so what I want to talk to you today about plantar fasciitis and a clinical evidence-based approach to it. So let's first of all break down the term plantar fasciitis. So plantar, the bottom of the foot, fascia, it's got the fascia on there, and itis, inflammation. So an inflamed fascia, the bottom of your foot. However, we already run into a problem, okay, because quite often, just like lateral epicondylitis, tennis elbow, very often there is no inflammation. Now, itis is inflammation. So tendinitis, inflammation of the tendon. Fasciitis, inflammation of the fascia. However, when it becomes chronic, very often there is no inflammation. So fasciitis is a term that we shouldn't be using. So then we might be talking about fasciosis, right? Which is a degeneration of the fascia. Just like with tennis elbow, we can call this a tendinopathy, which is an opathy meaning basically a problem with the tendon, tendinopathy. It could be a tendinitis, inflammation of the tendon, but if it's more chronic, it could be a tendinosis, degradation, degeneration of it. Same with the fascia. So, okay, so we can't even agree on the term because it's not always inflamed, fasciitis, it could be fasciosis, right? So it could be called heel spur, where you have an x-ray, you see a spur, policeman's foot, all of these different terms. So there's our first problem. What do we call it? Well, let's just call it anteromedial heel pain. Let's keep it simple, because on the heel, it's at the front there, the anterior portion, on the inside, the medial portion, so anteromedial heel pain. Right, let's get that out of the way first and foremost. We can't agree on what we should really call it. So what part of the population does this mainly affect? Well, we do know it affects people who are really active, like runners and joggers, especially if they ramp up their training. Just like anything, too much too soon can produce problems. You're overloading the tendons, or in this case, the fascia, potentially, right? So that is one group, okay? People that are really active, runners, sprinters, that sort of thing, jumpers, we know that. The other side of the population are 40 to 60-year-olds, so people getting up in age that are obese and sedentary. We know they are also major group of people that are affected. And when it comes to this, the one thing you most commonly hear about is when a person gets out of bed, it's that first 20 steps as they walk out of bed, and that's where they feel the pain, and then after a while, the pain starts to go away, unless it's really, really bad. Okay, so when it comes to treating it, this is very important, because if you're doing the golf ball under the foot or the frozen Coke bottle under the foot, you're not getting to the heart of the problem. It's only a piece of the problem, which I'll get into. So that talks about treatments, right? So what about the treatments? From the evidence, once again, well, so many treatments, ultrasound, steroid injections, acupuncture, dry needling, stretching, you name it, all of these are underwhelming, and I'll go into that in a little bit later. But so if we can't agree on the term, and we know that a lot of these therapies don't even work, there's not like one thing that goes, now, I know what you're saying, just like me, as an acupuncturist, I've had some great results with acupuncture, or you know, fill in the blank sort of treatment that's had fantastic results. You get those, but they can be just outliers, because the other 8 out of 10 didn't work, right? So that's what we're talking about. There's not like, this is the be-all, and right, you got it, okay? So, terminology, okay, treatment, What about the testing, the orthopedic tests? Now, they got to be reliable, don't they? Right, well, here's something I filmed earlier, and we'll talk about the orthopedic testing. I really want to show you the bottom of my foot, so, well, here goes nothing. It does smart, I gotta tell you, but I did this for my craft. Here we go, oh, we go, oi, oh, put that down, there we go, oh, there we go, my foot. That was ridiculous, wasn't it? I'd be the first to agree with you. How immature, cutting off my foot, making out like that. So now we've got, well, what about the testing? You know, the orthopedic test, surely they've got some validity. I mean, surely they work. No, look, you see, okay, look, the studies have also shown that even the testing methods, previous ones, right, because I'm going to show you new ones that have been shown to be effective, plus the treatments. So, well, let's just go. So, what have been currently used, this now the evidence shows it's lacking, right? So, what we do is the windlass test, okay? Commonly to diagnose plantar fasciitis, dorsiflexing this toe, puts a strain on the heel, should produce the pain. Well, okay, so now when we do an orthopedic test, what happens is we've got a thing called specificity and sensitivity. Specificity says, if I do that and it produces the pain, that test, and this test has a very high specificity, meaning if I do that, it tells you that you've got the problem. You've got plantar fasciitis, we'll call it, right? So very high specificity. However, sensitivity tells us if you don't have the problem. In other words, if I do that and you don't have plantar fasciitis, well, that's the sensitivity, which should be very high. So in other words, specificity will tell you, yep, you've got the disease, you've got the problem, so that's great. Well, that's very high. However, sensitivity should be high as well to tell us you don't have it. Unfortunately, doing this produced a whole heap of pain on people that didn't have the pain, the plantar fasciitis. So in other words, it's not reliable at all. The other thing is commonly is palpation. Just to palpate, is that really sore there? Okay, right. Well, once again, evidence has shown that even people that didn't have plantar fasciitis are really sensitive on this spot anyway. So that's not reliable either. So we need to do different clinical tests. Okay, so we now know that plantar fasciitis is not a term we can use for every single treatment because very often there is no itis, there is no inflammation. Right, so anterior medial heel pain is probably a better term, right? Because at least that tells us what it is. Okay, so we got that. We know also that a lot of the treatments, it's lacking evidence, quite frankly. They're very underwhelming. There's no definitive, this is the treatment you should have. Okay, so we got name, treatments, yeah. Okay, what about testing? Well, we know that also the testing have too many false negatives, so they're not reliable either. So, where does that leave us? That leaves us here, where I'm going to show you testing methods that have shown clinical significance and also why they're significant, so you know not only what to do, but why you're doing it, why they work, and then after that, we're going to look at how to treat it. Okay, so here's what the researchers found. So they found 3 tests that were very, very accurate at diagnosing anterior medial heel pain. Okay, so the first one, they get your client, get your client to stand on the affected foot. So just standing on one leg, and I'll show you in a second. But then they can stand and hold onto a chair if they like. You could hold their hands if you want, but they're just standing on one leg. Now, as soon as they feel pain, you stop it and find out where did they experience the pain. Okay, so that is the first one, just standing. Now, get them to stand like that for 30 seconds. What you want to do, again, this is all in your notes, so don't worry. So what you want to do, because you're going to reassess next time you see them, is how long, does the pain come on immediately? And test the seconds, maybe it came on at 12 seconds. Because then when you do that in the next treatment to reassess them, maybe it comes on, well, maybe it doesn't come on at all. Maybe it comes on at 20 seconds, which is obviously going to be better for them. Okay, so, but if as soon as the pain starts, you stop it, okay? If that's immediate, you stop it. So that's standing on one leg. The next one, and I'm going to go into what the theory is behind why this produces the pain. The next one is a one-leg standing heel raise, okay? So you get them just to do that. If that produces their pain immediately, that's it. If not, what you want to do is do 10 repetitions of the heel raise to try and bring on the pain. Once again, you'll note down whether, how many elevations did they have to do, heel raises, until the pain come on. Because again, when you reassess, maybe it doesn't come on at all next time. Or maybe it comes on, when it was 4, now it comes on after 8, and so on and so forth. And rating the amount of pain as well. And the third one is a one-legged squat as well, which I'll show you for the same reason. Now, the big question comes in, why would those produce the heel pain? Let me get my foot. So if you think about, okay, remember the windlass test that does this? If you would grab your foot and pull the toes there, that's basically what that is. Now, when we do a heel raise, we're bending the toes upright, but we're also plantar flexing the heel, okay? Because, of course, the calf's coming up like this. So that takes off pressure off the fascia. Right? So if I'm like this and I go like this, then that's it. But when we're going up on our toes, then you say we've got the calcaneus, there's plantar flexion. In other words, we're decreasing, so there's not so much fascial stretch. Why then is there pain there when there's not so much fascial stretch? Same when you do a one-leg squat. When you do a one-leg squat, because the knee bends when you're doing it, that dorsiflexion of the ankle, he's all locked up, but your dorsiflexion, so if you imagine the foot's going that way as you do that squat, your knee goes over the front of your foot, that's also taking off pressure from the fascia. So why is that producing pain as well? So what the authors of the studies thought that, okay, so what is happening each time? Well, when we go up on our toes, so listen, this is important, you know this, when we go up on our toes, because this is what the treatment's going to be all about, when we go up on the toes, what we're doing to do that heel raise is contracting concentrically, quick physiology lesson, a concentric contraction. So we've got concentric, eccentric. Concentric is when the joints are coming closer together, a biceps curl like that. Eccentric is where you're putting the brakes on the muscle as it goes down. So when we're doing this, coming up, we concentrically contract our calf muscle and it produces pain. What's going on in that calf, hey? What's going on? Now, when you are doing a squat, you are eccentrically contracting the calf, which brings on the pain. So, we're starting to think something is going on in those calf muscles which are referring the pain. Now, there's the medial. Now, here's something that's also really interesting. These muscles do not go, there's no musculature in the heel. There's a fat pad and other bits and pieces, but there's no muscle. So it's not like the muscles come around and attach it. No, they go around the heel, okay? What there are nerves. So what the thinking is, it could be trigger points referring down here. So just think referred pain from the calf, okay? Referred pain from the calf. It could be nerves. There's a medial calcaneal nerve that goes through here. That nerve, and again, they don't know whether, let's say the nerve became dysfunctional and then the muscles contracted around it, protect the area, and that's what brought on this dysfunctional nerve pain, but it could also be trigger point pain from these tight muscles as well. So you'll find these tight bands, and that's what we address, because that's what they found when it comes to treating these muscles, which I'll go into, treating these muscles of the calf helps with the heel pain. So think of it as there might be some fascial restriction, that sort of thing, but they're treating these calf muscles, as you're going to find out, helps with this. So start thinking of as whether it's nerve and or trigger point related, referring to there, because when we're doing this, there's not so much of a fascial stretch. It's contracting the calf muscle concentrically and eccentrically in those assessments. So that, just put that back in the back of your mind, because that is where we're starting to look at. It's a calf problem, not a fascial problem, not a complete fascial problem. Yes, there's much going on, but this pain seems to be referred. So that's what we're going to look at. Okay, so now I hope you've got a much better understanding of what's going on, how to test it, and why you're testing it, and what's going on there. The next step, as promised, is what I'm going to do in the next video, is show you how to treat it successfully.